I said with 5, just get out of here with 5.
I can do that. All right, we are going to resume our task force meeting. I'm going to ask Jamie Kavanaugh. I don't remember where you stopped off, but I'm sure you do. And if you can go ahead and continue your presentation, and then we'll follow up with any questions that we have.
Of course, thank you. Yeah, I'm reaching the end. We are talking about one of the lawsuits challenging Kentucky's Certificate of Need law. It was holding back Nepali immigrants from opening a home health agency for their community. And when Chief Judge Jeffrey Sutton on the Sixth Circuit issued his opinion, he said, yes, I'm forced to uphold this law because of Supreme Court precedent that requires courts to uphold laws as long as the government gives any plausible reason, even if the laws are unfair, unjust, or unwise. But he did make a plea to the legislature in his opinion and wrote, the judgment that Certificate of Need laws are a failed experiment has a ring of truth to it. Were we Kentucky legislators ourselves, we would be inclined to think that Certificate of Need laws should be the exception, not the rule, and perhaps have outlived their own need. So that was his understanding of Certificate of Need laws. And then recently, earlier this month, the Certificate of Need law for ambulance providers was found partially unconstitutional as applied to out-of-state providers. So a out-of-state ambulance provider from Ohio was able to bring patients to Kentucky without a Certificate of Need, but it couldn't turn around and take those same patients from Kentucky back to Ohio. And they challenged that. That was brought by the Pacific Legal Foundation. And the court said Kentucky can apply the Certificate of Need laws to in-state providers, but it can't restrict out-of-state providers in that way. And made a specific finding that the economic protectionism for incumbent in-state providers created by the Certificate of Need laws is unconstitutional. So again, recognizing one of the problems with Certificate of Need laws. The court also noted that the human costs of Certificate of Need laws, those are inflated prices, limited access, and decreased quality, are costs that the Kentucky legislature has inflicted on its own people. That's a direct quote from the court. Okay, so finally I want to talk about a couple examples of the consequences of limiting the supply of healthcare. So of course, during COVID, we saw that we had to suspend Certificate of Need laws to allow hospitals to have the flexibility to respond to pandemic surges. States with Certificate of Need laws were 27% more likely to run out of hospital beds. And of course, that makes sense because we've been restricting the supply of healthcare facilities for decades. But even outside of the pandemic context, more recently, we've seen kind of the dire consequences of Certificate of Need laws. In March 2023, Governor Beshear approved some emergency regulations in response to the dire lack of psychiatric care facilities here in the Commonwealth. The cabinet has known since 2013 that Kentucky has been lacking in psychiatric care facilities. It commissioned a capacity report back in 2013, and the report found, quote, utilization of inpatient psychiatric care is about 50% higher in Kentucky than the national benchmark. And the report recommended increasing these facilities, increasing the number of these facilities. But unfortunately, that hasn't happened. And so this has been a whole decade where we haven't really increased access to services in Kentucky. And then in 2021, Marian Elizabeth Hospital in Louisville filed a Certificate of Need application asking to change some of its acute care beds to psychiatric care beds. This application was denied. The cabinet denied the Certificate of Need application. And those are 33 beds that could have come online back in 2021. And Marian Elizabeth is the provider on the ground saying these are the circumstances and we need to respond to what we're seeing. We want to be able to help the patients. And unfortunately, the Certificate of Need laws stood in the way. But the emergency regulations that Governor Beshear signed in March of this year allow Marion Elizabeth to go back now and apply for, file basically an identical application. So it really makes no sense that this application was denied 2 years ago, and now we had to wait for Governor Beshear to implement emergency regulations. We had to wait for it to get so bad that he said there's this critical shortage of mental health services. And now that we're behind the ball, we're trying to play catch up when there were facilities that were trying to stay on top of demand during this time. And then a few months later, in May 2023, Governor Beshear signed a second set of emergency regulations. This was to address the ongoing shortage of ambulance services throughout the Commonwealth. This is another service that was well known that Kentucky didn't have enough access to. And disturbingly, since 2021, the cabinet has denied at least 11 certificate of need applications to provide ground ambulance services. So again, these are providers that could have been alleviating this critical shortage over the last few years. So I wanted to end there, but make sure that you were aware of these actual on-the-ground examples of patients being harmed by the lack of access to care here. And I'm happy to answer questions.
Thank you. Thank you for your presentation. We do have a couple questions. Begin with Senator Meredith.
Thank you, Mr. Chair, and thank you for your testimony this morning, interrupted as it was. Your statement that there's no evidence that hospitals rely on cost shifting is kind of bewildering to me. So you will acknowledge that for hospitals, Medicare only pays 1% of the cost, not charges.
Correct.
Just 1%.
That was part
and
of
that
my
runs about
presentation.
80% of cost.
Yes.
You would acknowledge that Medicaid pays less than Medicare. It's about 66% of Medicare.
Yes.
Now, in rural hospitals, the majority of the patients are either Medicare or Medicaid, can run from 60 to 80%. If you're not even recovering your costs, that's a pretty failed business model. Wouldn't you acknowledge that?
Right. This is the difference between cross-subsidization and cost shifting.
Well, that's one point I'm trying to get to, that if 60 to 75% of your patients you're not even receiving your cost from, how do they survive financially?
I understand that they use cross-subsidization.
Exactly. So I don't know how you can say that there's
But
no evidence that hospitals rely on cost
I can
shifting.
provide you
Every
the
hospital
evidence.
relies on cost shifting. It's significant.
But if that were true, what you're saying, then the hospitals with higher payer mixes of government
No,
payers
that's not
would
true.
have to charge higher prices.
We don't set the prices. The government sets the prices.
I'm not talking about the government prices. I'm talking about what you're relying on, the prices for the private.
I never
insured
could raise
patients.
my price as a hospital CEO because Medicare and Medicaid cut their funding, because that is set. We don't determine that. We're at the mercy of Medicare and Medicaid and the commercial insurance companies. That cost shifting you're talking about, it's the only way that rural hospitals can survive. So to say that it's a myth, that's a misleading statement. You make the statement, if hospitals relied on cost shifting, we'd expect to see more reimbursement or higher. We'd see hospital rises in prices with uniformity when the government lowers reimbursement rates. That's not true. There's no relationship with there whatsoever. We can raise them as much as we want to, but nobody's going to pay for them. So it doesn't increase the cost of health care. That's not true that cost shifting is a myth. We have to rely on that. They
Right.
cannot survive. It's a pure economic model. You have to acknowledge.
Right, that's cross-subsidization. That's different than relying completely on cost shifting. I can provide you the data. I'd be happy to.
No, because the data can be manipulated. I'm talking about real world experiences here. Talking about 40 years of healthcare experience.
Absolutely.
That Medicare, Medicaid does not pay the cost. That has to be passed on to the commercial pay patients and the private pay patients.
And
It's imperative for rural hospitals to survive. So to say that there's a myth relying on cost shift, it's not a true statement. It's what drives the system. We didn't create the system, the government did. So if there's a limited commercial pay base in your rural communities, which you are, and I hope you acknowledge that as well, we don't have a lot of commercial pay patients. If you open up certificate of need and let another hospital come in, then that's going to dilute that pie. How does that make the situation for rural hospitals better financially?
well, what we actually see in states without certificate of need laws is that there are more rural hospitals per capita, and more rural
I'm
surgery
talking real
centers
life
per
again.
capita.
The example I gave
This is
you,
real
if
life.
you
This
can't
is real
get a
data.
percentage of your
This is real
reimbursement
data.
to the commercial pay patients, you're not going to survive. And
Right, I'm trying to address your question.
To say the certificate of need doesn't keep hospitals from closing, I would have to disagree with that as well.
So there are more rural hospitals per capita in states that don't have certificate of need, and there's also more rural surgery centers per capita. So this phenomenon of the privately paid, privately insured patients leaving and going to the surgery centers, and then the hospital somehow closing because they can't make up their margins, that doesn't happen. There's more of both facilities in states without certificate of need because this argument that you're making relies on the fact that we would only have a limited number of patients.
We do. In the
And-
rural community, you do have a limited number of patients.
In fact,
It's
when
not
more
unlimited.
facilities open, more people have access to care, and all of a sudden we have more patients seeking care, which is a good thing. We want to make sure that everyone has access to the care that they need.
No, what you're going to get is when you open it up is you are going to have the cherry picking that you've alluded to, but try to discount. Particularly in my community, what I see is a freestanding surgery center, a freestanding imaging center that's going to take the private pay and commercial pay patients, which is going to further dilute the revenue base for the rural hospital. So I don't know how you can say this does not have an impact on rural hospitals and rural communities, because it most certainly does. We don't have an unlimited number of commercial pay patients that we can split amongst ourselves. It does give us a monopoly, but it's a neat monopoly to provide needed services for your community. Otherwise, how do you pay for ER? How do you pay for OB services? How do we pay for inpatient care? All those things have to be cross-subsidized by someone. It's not being cross-subsidized by the government. So again, you dilute the commercial pay payer base, there's nothing left for the rural hospital.
Well, the issue with reimbursement rates isn't an issue that Certificate of Need, unfortunately, was designed to address.
No, but certificate of need has been altered numerous times since its inception. We all agree it's different from its original intent, but it's to provide some guarantee of access to care. Without it, you've got no guarantee whatsoever.
Well, 12% of the adult population in Kentucky still says that they go without care because they're worried about cost.
No, what they're worried about is the lack of health care providers. 40% of our population in Kentucky is rural. Only 17% of our primary care physicians are there. And it goes back to reimbursement. That's the issues that we need to be addressing, is the inequities of the reimbursement system for the federal government and the insurance companies that are denying health care to citizens, not just in rural areas, but urban deserts as well.
Absolutely.
They're there because of the lack of funding and reimbursement. It's got nothing to do with certificate of need.
I agree.
Increasing competition, all that does is provide more places for people to go to, but doesn't improve the quality of care. And what are you going to do in a situation, particularly now in Kentucky, where we have a shortage of physicians and nurses? Something like 10,000 nurses. We're going to divide that pie even more by opening up any healthcare provider that wants to provide the service can provide the service. It makes no sense whatsoever.
Well, you would have
The
had more
purpose of
providers
certificate of need
here
today
without
is to ensure
certificate of need.
access to care for rural communities. It is.
We're going to move on. We have one more question. Senator Berg.
Thank you. I actually have two questions, so I'm trying to decide which one. You said we had a critical shortage of ambulance providers, a critical shortage of inpatient psychiatric beds is what you were talking about. What other critical facility shortages, not provider, because obviously we have tremendous provider shortages, facility shortages, do you think that lifting the CON in this state would solve?
I don't know what facilities would open, but that's why we need to allow the providers to see what their patients need.
No, my question was, what is the shortage? Where is the critical shortage that we need to address? You mentioned ambulance providers. You mentioned inpatient psychiatric beds. What other critical facility shortages do you see us having in this state that lifting CON would address in a positive way from your perspective?
The 2013 capacity report that the Commonwealth commissioned recommended getting rid of certificate of need for home health care and for imaging centers. It said that the market for imaging centers levels itself. We've already removed certificate of need for a lot of different imaging services, so there's no need to keep it for the few imaging center services that remain. And it also recommended getting rid of certificate of need for home health, in addition to the problems with access to psychiatric beds.
So we're talking about ambulance services, inpatient psychiatric beds, home health services, and freestanding imaging centers.
I'm not saying those are the only services.
Well, I'm
that we
asking the
help.
question, where do we have a critical need that lifting CON? That was my question. Other facilities, or this is it?
Yeah, we have to let the physicians listen to their patients and respond to what their patients need. 12% of patients in Kentucky are saying that they can't get care because of the costs. I think the physicians and the providers are going to know the best way to respond to that shortage.
Okay, thank you. Thank you. Do I have time for a second question?
You do.
Oh my God, thank you. This is a difficult word for me to pronounce. I actually wrote it down before the fire so that I would try to do it correctly. Can you explain to me, in your mind, the difference between cost subsidization and cost shifting? How do you delineate those two?
Sure. Cost shifting means that the hospitals are completely reliant on this line of services. Cross subsidization is what happens in any business. Of course, you make a higher margin on some services or some products than you do on other services, like how fast food restaurants make more money on soda than they do on certain other foods that they sell. And of course, that happens in healthcare. That happens in any type of business.
So then when you're doing your balance sheet, what's the difference?
The difference is that we still see hospitals in competitive markets being able to lower prices to be competitive with each other. And so that undercuts the argument that hospitals are 100% reliant on cost shifting.
Okay. So you're saying that hospitals will actually lower their costs if another hospital opens up and provides the same service at a lower cost. I don't know how. I mean, I'm a provider. I've been a provider for a long, long time. I can't even figure out what my hospital charges for a particular service. I don't think most consumers know that, whether you have private insurance or not. I do not understand, honestly, in a world where the reimbursements are set for us. I mean, we can negotiate them. Hospitals, the larger hospital system is, the more negotiating power you may have with an insurance company. But ultimately, we don't get to decide what we charge. The insurance companies decide what they will pay us. So it's like we have to fix that first before we can
Absolutely.
fix this.
Reimbursement rates are a huge problem, but that's not what certificate of need is designed to address.
Thanks.
Thank you for your presentation. I do appreciate it. Thank you, members, for the questions. We are now going to move on to the final presenter. We have Matthew Mitchell is online. Are you there, Matthew?
I am, yes. Can you all hear me?
Yes. Going to ask you to introduce yourself for the record. And then I'll administer the oath, and then after that you can present. I will ask you to be mindful in your presentation that we did have an interruption in our task force meeting, and so everyone's schedules have been thrown off. So where you're able to abbreviate, please do so, and then we'll open it up for questions afterwards.
Sounds good. So my name is Matthew Mitchell. I'm a senior research fellow at the NIE Regulatory Research Center at West Virginia University.
Would you raise your right hand, please? All right. Do you swear to tell the whole truth and nothing but the truth?
I do.
All right. Thank you. You may begin.
All right. Thank you so much. So in my role as a economist at the Regulatory Research Center and my previous role at George Mason University, I've spent basically about the better part of a decade looking at certificate of need laws. And my effort here, as briefly as possible, is to kind of give you a sense of what the literature is. So my game plan is essentially three things: talk about what the nature of a certificate of need regulation, very short history lesson, and then I'm going to spend most of the time on the literature. I don't think I need to spend too much time on what a certificate of need is, especially since this is the fourth meeting for you all, and I'm sure you are becoming experts in the issue. What I would say is, from the perspective of an economist, what is important about a certificate of need law, it's a relatively unusual regulation. The vast majority of markets, 95, 99% of markets, have nothing like this. It is unusual insofar as it is not designed to assess a provider's qualifications, the cleanliness of their facilities, the adequacy of the facilities. Instead, it is entirely designed to second guess the provider's belief that their service is needed. Normally, assessment of need is done on in every other market with an entrepreneur who decides they want to offer a service, and they determine whether it's going to be a profitable service based on the customer base. What is particularly interesting from here's a number of services that Kentucky regulates. You can go into greater detail on this. We can look at it in the report that Ms. Kavanaugh and I co-authored. What I want to highlight here is that what's particularly important from an economic perspective is that certificate of need laws have a number of anti-competitive features. So first of all, competitors, it's very unusual to have a regulation in which competitors are actually allowed to weigh in on the process. I should note that there are actually 5 certificate of need states that do not allow competitors to be involved, but Kentucky is not among them. Often a certificate of need will be denied based on the regulations simply if it can be shown that a new provider will duplicate an existing service. So this use of the phrase duplication is pretty interesting and unusual. What the regulations call duplication, patients and providers would call competition. So essentially this guarantees a local monopoly. And then finally, there's also the formulas. If you think through the way the formula works, this too provides a significant incumbent provider benefit. So if I know that a potential competitor is likely to have their certificate of need denied, if I have a lot of hospital beds and I make sure that they're empty, that's the way the formula works. A larger percentage of empty beds essentially makes it more likely that a con will be denied. Then I have an incentive to acquire medical equipment and make sure it goes unused. This is ironic, of course, because this is exactly the opposite of what con was intended to do, which was to discourage the use of the acquisition of unneeded resources. But it also provides, again, a handy way for an incumbent provider to box out the competition. Okay, so very briefly on the history, the reason I want to go over this is to give you a sense of why it is that we have such a robust understanding of the way certificate of need laws actually work. The basic history is that certificate of need laws had begun in a few states. New York, I think, was the pioneer in 1964. Kentucky's, I believe, came online in 1972. But the federal government gave a big boost in 1974. This was part of the Nixon administration, and then Nixon was out by the time the law made its way through Congress and President Ford signed it. Within a decade, there was already quite a bit of evidence to suggest that con laws were not working as intended. And so a Democratic Congress and a Republican President Reagan repealed the federal mandate encouraging states to adopt certificate of need laws. As you can see, some in Congress wanted to go further. This is Representative Roy Rowland. He's a physician who represents a rural area in Georgia. He wanted the feds to actually outlaw certificate of need regulation at the state level. He didn't get his wish. So now what we end up having is this system where many states have certificate of need laws, many states don't. They've repealed them over time. There's 2022. If you go to 2024, you can see after reforms, particularly in Montana and South Carolina, that's the way it's going to look in 2024. The interesting thing here is that this provides a wealth of data for us to study. So about 40% of Americans live in a state with either no certificate of need law in healthcare or a very limited certificate of need law in healthcare. My home state of New Mexico has only requires a certificate of need for ambulance services, for example. The states with and without con laws are rural, urban, coastal, intercontinental, high income, low income. They provide a really nice cross section of the country. And because they've repealed and changed the laws over time, we have what economists would call perfect sort of scenario to look at a natural experiment. So this is a popular bumper sticker among certain dorky economists. I love federalism, but for the natural experiments, this is very much a good environment for a natural experiment. So as a result of this, certificate of need laws are an extraordinarily well-studied public policy. In fact, in 20 years of looking at public policies, I'm not aware of any single regulation that has quite so many separate peer-reviewed studies. So what I'm going to focus on is 127 peer-reviewed studies. That is, these are studies that have been published in academic journals. In a few cases, I also include a few government reports that were done by academics at the request of the government. Most studies look at more than one question. So it's actually 127 studies, but it really amounts to 415 separate tests. What I'm going to talk about today is four areas of this research: tests that assess the effect of con on spending, on access, on quality, and underserved populations. The biggest thing I want to emphasize is that this is the real world here. We're not talking about theory. I have 0 studies that are looking at just the theory of certificate of need. We're looking at actual patients, actual providers, real world experience. So how does con affect spending? There are 3 different ways that the literature has assessed this question. One is to look at spending per service. You can think of this as the analog to a price. Another is to look at how much, whether con affects spending per person. And then the final, and I would argue actually probably the least helpful way to look at it is as some kind of measure of efficiency by looking at output per input. So I'm going to briefly describe these. 43 separate tests have assessed the effect of con on spending per service. You can think of this as price. For every test that finds that con is associated with lower spending per service, there are 5 times as many that find that it's associated with higher spending per service. So what does this mean? Well, it means in states that repeal con laws, for example, reimbursement costs for coronary artery bypass grafts fell in Ohio and in Pennsylvania following con repeal. Hospital charges are about 5.5% lower in repealing states 5 years after repeal. Medicare reimbursement for total knee arthroplasty are about 5 to 10% lower in non-con states relative to con states. Spinal surgery reimbursements fall faster in non-con states than in con states. These is just a smattering of the example, but to give you a sense of this literature. But basically, in the real world, we find that spending per service is higher in con states than in non-con states, and it falls after repeal. What about how much we spend per patient or per person? Here too, the tests are pretty clear. 46% of all the tests, there's been 50 tests in total, find that con is associated with higher spending per person, not lower spending per person. To give you an idea of this, Medicaid community-based care expenditures are higher in con states than in non-con states. Hospital expenditures per adjusted admission are higher in con states. States that eliminate con experience a 5% reduction in real per capita healthcare spending. Medicare spending per rural beneficiary is higher in con states than in non-con states. The effect on efficiency is more mixed. We would expect it to be mixed. On the one hand, state providers that are protected from competition tend to have what economists call greater X inefficiencies. They're not as efficient at providing. So that might make services less efficient in con states. On the other hand, if you have only one provider because of con, and they have to channel a lot of services through their capital, then the output per input can actually be higher. So it's basically, this isn't as well studied an area of research. There's only been 10 tests, and they're relatively mixed. To give you a sense, I actually authored one of the tests that found con was associated with higher efficiency, so measured. But to give you a sense of this was the study that Ms. Kavanaugh mentioned, where we found, a colleague of mine and I found that during COVID, hospitals in con states were 27% more likely to run out of beds than in non-con states. So that's a problem with access. But it turns out that if you have fewer beds and you fill them more during an emergency like con, lo and behold, that actually means higher efficiency. In my view, I think actually measures of of spending that look at spending per person or spending per service are more informative than figuring out that we're using beds, we're having more people in beds. The next area of research that has been studied quite extensively is access. And the basic idea here is that access is probably likely to go down if we have fewer services. However, as George Stigler, Nobel laureate in economics, pointed out in a famous paper on regulatory economics, if you limit the provision of some types of services, you can certainly, that may end up meaning that there's greater utilization of other types of services. The literature has basically addressed this in two ways. One is to look at are services easily available? And then the second is, do people actually use the services? So on the first question, it's pretty lopsided. There have been 80 tests, 10 times as many tests find that con is associated with diminished access or availability of services than have found that it's associated with greater access. In terms of utilization, it's much more mixed. Even though it's harder to find services, healthcare is a inelastically demand service, which means that even if it's difficult to get care, patients often will still go to great lengths to obtain care. So it's a little bit more mixed, but still there's twice as many tests that find that people con is associated with diminished utilization of services as find that it's associated with greater utilization of services. To give you a sense of this literature, 171 tests have assessed the effect of con in total. That's both the utilization and the access branches of that literature. It's by far the most studied aspect, and it's really pretty clear here. So the typical patient in a con state has access to fewer hospitals, about 30% fewer hospitals. They have access to fewer ambulatory surgery centers, about 14% fewer. They have access to fewer hospice care facilities, dialysis clinics, cancer treatment facilities, home health agencies, psychiatric care facilities, drug and substance abuse centers, open heart surgery programs, revascularization programs, percutaneous coronary intervention programs. There are fewer rural hospitals in con states as well as rural ambulatory surgery centers. The numbers there are 40% and 13% respectively. So again, in a state like Kentucky where you've got 40% rural population, it's absolutely critical that these hard to reach areas have access to care. The very best real world data that we can find, it's been shown in multiple studies, suggests that you will increase access to care if you stop limiting it through con. Patients in these states have access to fewer hospital beds. You're more likely to be denied beds during COVID. Fewer medical imaging services. Patients actually in con states are more likely to travel longer distances for care and to leave the state in search of care. Let me very briefly talk about the last two areas, quality and underserved populations. It's possible quality could increase or decrease as a result of con. The case for con increasing quality is that we do know that competition, even in healthcare, does tend to improve with greater competition. On the other hand, there is an argument that providers, as they have greater volume offer a greater volume of services, maybe they'll get better at the services. So theoretically, we're not sure. So we have to turn to the data. What does that data show? Well, sure enough, as with the other areas, the data suggests that the vast majority of the data suggests that con probably undermines the quality of care. Pretty well studied, 90 tests have looked at this. What kinds of things are worse in con states like Kentucky relative to non-con states? Well, patients experience higher mortality rates following heart attack, heart failure, and pneumonia, higher readmission rates, higher death rates from post-surgery complications. Patients are less likely to give their hospitals a 9 or a 10 on a 10-point rating, lower nursing home ratings, lower nursing home health agency scores. Nursing home patients are actually more likely to be physically restrained in con states relative to non-con states. Home health agency clients are less likely to see improvements in mobility. Surgeries are more likely to be performed by lower quality surgeons with poor records. And most of the, let me address real briefly the opposite side. Most of the studies that find that con is associated with higher quality, essentially what they're looking at is, does con suppress unwarranted or expensive procedures? And there is some evidence that it might do that, but it's at the cost of these other types of quality metrics. Finally, it's often argued that CON is needed to help underserved populations, especially rural populations or minorities. This is one where there is actually, among 13 tests, 0 find that CON is associated with increased or better care for underserved populations. 3 tests find mixed results. 77% of the sample associate CON with diminished care for underserved populations. So, for example, rural hospitals in CON states are less likely to adapt to patient needs. Safety net hospitals in CON states actually have lower margins. This is interesting in light of the question about cross-subsidization. A large black-white disparity, I think it was about 48% in angiography, disappeared after CON repeal in New Jersey, repeal of CON on that particular service. And then there's no difference in charity care between CON and non-CON states. So it's often argued that we'll see greater provision of care to charity care. There's just no statistically significant evidence of that whatsoever. So here's sort of the broad overview of the literature, putting everything together, all the tests. For every one test that finds that CON is associated with a good result, the real world actual experience of looking at what patients are dealing with on a day-to-day basis suggests that there are 5 studies finding or tests finding bad results. So, the balance of evidence from an economist perspective is that CON behaves pretty much exactly as an economist would think it would. It's a limit on supply, which tends to be associated with higher costs, diminished provision of services, and undermines quality. So that's kind of as quickly as I can, 4 decades of research on certificate of need laws. I look forward to answering any questions you might have.
Thank you, Dr. Mitchell. Do we have any questions from members of the task force? I think the day has worn us down. I want to thank you for your presentation, for participating today. I want to thank everyone for working with us with the fire alarm that went off and delayed everything. But I do think we have important work here in the testimony that we hear today, and I want to thank everyone for hanging around and participating. I do have one announcement related to the next meeting of the task force. We will meet on Thursday, October the 19th. We'll be meeting at a different time as well at 11 a.m. Instead of our typical 10:30. So I want to remind everyone of that. Seeing no questions, Senator Douglas, do you have anything to share?
Not at this time, Mr. Chair.
Thank you. I would entertain a motion to adjourn.
Motion to adjourn.
Motion, do we have a second? Second by Senator Berg.